going to hear from Alan on HIV, aging, and cure research. Alan is a professor of medicine at the University of Texas Medical Branch. We're going to have him come up, share a little bit about himself, and then go right into talk. Give it up for Alan.
Well, we just heard a really great story from a young investigator who's an immunologist. A young immunologist. I'm the other end of the spectrum. I just turned 70, and I've been doing HIV research for 44 years, since 1981. I started in the lab of Max Cooper, and I'm working in a part of the country in Birmingham, Alabama, in 1981, where I'm in the Lorleen B. Wallace Tumor Institute. And guess who that was named for? That was George Wallace's second wife. George is still alive, and I met George Wallace. He would come to the place in his wheelchair, and it was an interesting experience to have met George Wallace. But I'm in the South dealing with a new disease that's just been discovered in the gay community, and I'm working actually on hemophiliacs. And that's how I got involved in HIV research 44 years ago, with a hematologist who came to my boss, Dr. Max Cooper, a very famous immunologist who discovered B cells. So if any of you, we talked a lot about antibodies today. B cells make those antibodies, and Max Cooper, who I work with, discovered those B cells. I'm still hoping he'll get a Nobel Prize for it. He got a Lasker Award, which is the prelude to that. He's now at Emory. He left Birmingham because they said he was too old at 75 to continue working and be productive. He went to Emory. He's now 92 and still runs his lab and publishes more science and stuff than anybody I know. So that's a tribute to think about the longevity of people. And as I'll talk about aging, we're going to talk about healthy aging and health span today about that. So my story in aging started there, but I'm actually now the head of the Seeley Center on Aging in Galveston. I retired from a job of 40 years in Chicago at Rush University. Having done that, I met many of you there. I actually had a developmental center for age research. Dawn was on my advisory committee, so I'd like to thank her for all her help and the work we did there. And I've worked with many of you in the community over the years. I started in the community work in immunology with Marty Delaney back in the Project Inform and Project Immunoconstitution. We were looking at thymic transplants, you remember back then, and we were looking at the bone marrow transplants and some very interesting days in the 80s, looking at the early days of immunology. So I've learned a lot, and I've really taken that aspect of what I learned in 40 years of HIV, applied it in COVID, and now I'm applying it more broadly in aging. So as we heard from our previous speaker, the idea is that HIV teaches us a lot to really work within the whole broad field of medicine, because now our patients are dealing with cardiovascular disease, they're dealing with brain health, they're dealing with metabolic diseases, they're dealing with cancer, of course. And all of these things we're learning about from HIV and can apply more broadly to the field. And so that's what I've been doing, is building the field I'll talk about today of geroscience. And that has also been worked at the NIH. So I'll start there and talk about understanding biologic aging and its implications for cure. Okay, thanks. So again, as we all know, the US population is aging, and so is our HIV, persons living with HIV population. People diagnosed are living longer and healthier lives because of the treatment. And this is now a global effect. We know that very much, that we're growing our population. And it's not just in the US, but it's also in parts of Africa, Asia, South America. And I'm really now myself trying to bring together those cohorts and those groups from across the country. I was recently in South Africa meeting with Linda Gale Becker, who many of you will know in her work in lenacapavir and HIV prevention. Well, Linda Gale and I are now helping form an aging HIV cohort in South Africa. And we're working on that. And she's developing guidelines for aging, which is a critical part that we're trying to work on for all of our patients living with HIV across the world. What kind of guidelines can we give to the physicians who care for the older HIV population? That's a critical part of what we're doing. And I'm trying to do that across, not just in the US setting, but across the world with people like Linda Gale, and also with Beatrice Grinstein, who, as you know, is the current president of the International AIDS Society from Brazil, working with her, working with Cecile Tremblay in Canada, and working with others in Asia as well, who are very much involved in this field. So it's really a global effort in what I'm doing. Next slide. And then here we go, is that 54% in the US are over 50. So I think, again, it speaks to the fact that when clinicians are talking to their patients today, they have to think about what are the diseases that come in aging, but at an earlier age. And we were one of the first groups to start to think about this back in 2010. We actually had our first discussions of HIV and aging over 15 years ago. And we had a committee at the Office of AIDS Research that Paolo Miotti headed up at the time. And I was there with Paul Volberding. Most of you will know Paul, since he's from here in San Francisco and started the AIDS work here. He's a hemonc doc, so he came from the cancer field, of course. And then was also Kevin High was a partner there. So we really started thinking about this whole concept of HIV and aging way back in the early days now to try to engage our communities. Next. So how does aging with HIV affect the patient's overall health and cure strategies? Because as you look at applying cure strategies today, who's the target audience? It's people over 50. And these are going to be people that are going to have all these other comorbidities and the other aspects of accelerated or accentuated aging. And we heard before about inflammation. That's going to be a big part of it. Inflammation persists, even in those individuals treated in the earliest acute infection. Next slide. So connecting the core themes of my presentation, just go through it. So we know that aging drives inflammation and HIV itself can drive inflammation. So does aging with HIV and HIV synergistically affect our patients? So you're aging, so there's a natural effect of aging on inflammation, and a lot of it affects the gut. We actually, almost 15 years ago, did the first work with Danny Dewick, some of you know from the NIH, and Jason Brenchley, looking at the gut and the gut permeability. And you may have heard the term leaky gut. Well, that occurs very early on in HIV, but it also occurs during aging. So people in their 60s and 70s, when you look for those products from the gut, the microbial translocation, they're present, as you also see in a younger HIV population. So there's very similar things going on, we heard, in HIV and in aging. And so we have to consider, when people are now in their 50s and 60s, is this the perfect storm? And now we're going to try to actually think about how do we cure individuals at that age. And now we have this underlying effects on the immune system, which is critical to a cure strategy. Next slide. So I'm just going to give a garden analogy of HIV, aging, and inflammation. Next. You can just click through. So HIV could be a super fertilizer that really accelerates plant growth, aging, but not in a healthy way. Okay? Then you have chronic inflammation. All of this is the weeds, and we need to get that out. And it's going to choke out the healthy growth and stress the soil. So that's what we need to look at. So we need to now look at a new concept, patient-centered care. Many of you who've gone to International AIDS Society meetings over the years, that's really a new theme that they're undertaking globally, looking at the whole individual. And that's what we need to think about even as we think about, I know that's why they're talking, we've heard a lot about what's going on at the NIH. Well, the NIH is divided up by your organs. You look at your heart, you look at your lungs, you look at your liver. Is that the way you should be looked at as a person? No, you should be looked at as a whole person. And that's what we're thinking, that's what we really have to think about in HIV and aging, is the whole person. What happens to their overall physical ability, mental ability? What about the stressors, mental health, their living conditions, their lifestyle? All of that has to come into play. And as you're aging, you're going to have even more and many other effects that I'll talk about. Next. So we have exciting new gardening approaches, a new term called geroscience, and I'll define those in a moment, and new gardening tools, medicines, which are called cynotherapeutics, that have the potential to have a big impact in HIV, and they also, those same agents can affect an HIV cure. So it's, again, a bigger bang for your buck by these. Next. So here are some of the terms I'll define. Geroscience the study of the biologic processes that cause aging. We also have, people may have heard about senescence. That's where cells lose the ability to create new cells, but they don't die. Senescent cells are immortal cells, or what people might call zombies. You know, when people die and come back to life and don't die. And I don't know how do you get rid of a zombie? I'm not really sure.
Shoot it in the brain.
Cut their head off. Thank you. Yes, thank you. I thought that might have been the answer. Cut their head off. And the fact is that the source of these inflammatory mediators in aging is the senescent cells. So the senescent cells accumulate and make all the inflammatory mediators. So now you're going to have a double whammy of HIV driving inflammation, and now the aging process driving inflammation. And so that really affects the outcomes. And then you have the ideas of cytokines we've talked about and pro-inflammation that triggers. Next slide. So again, this is very much out in the public domain. I was shopping a few months ago and picked this up in the grocery store, the cover of National Geographic. Anti-inflammation, the science of inflammation and ways to treat it. So again, this is out very much in everybody's understanding and thinking about inflammation. This is a common term everybody in this room probably has heard of, but it's very critical to HIV cure research in aging. Next. So there's another new term is we have what's called lifespan and health span. So lifespan is how long you live. Now you could live to 100 or you could live to 70. And it may be that in that last 30 years, though, you may be in a bedridden, you may be in a nursing home, you may be in a wheelchair, and you know you're isolated from your friends and family. That's not what you want. You want a good health span. If you're going to live to 100, you want to be out golfing, surfing. I was just in New Zealand wine drinking. I was out seeing the hobbits in Hobbiton. So I got to visit hobbits, Jeff. Yes. I got to see hobbits for the first time out in the field. Huh?
What is that?
The hobbits are the tiny people from Lord of the Rings.
Are you serious? New Zealand?
Actually, yeah. So the director of the whole series is Peter Jackson. Peter is New Zealand, and the place I was a farm where you could go to Hobbiton and see the movie set.
Oh, you don't see real little people. After enough wine, enough wine.
Exactly. So, anyways, we're looking at this idea now of health span, and so the field of geroscience is moving from consideration of lifespan, which is longevity. So you've heard of a term, longevity. You want to live a long life. It's not living a long life. It's living a healthy life, a long, healthy life, and that's really critical. And it's all aspects. Again, person-centered care. It's mental health, physical health, and so on. And we're characterizing health span, again, neuromuscular function, cognitive, brain health, cardiovascular, metabolic, whether you're going to get diabetes, inflammation, body composition, do you gain weight, how's your mobility, how's your bone and muscle strength. These are all critical parts of looking. Okay, and then there's a shift towards delay. I'm sorry. Just go back one. Yep. There's a shift toward delaying and compressing the period of lifespan when frailty, which is again your ability to move, and disability increase. So therefore extending and improving health span. So we want to have those periods of frailty only a couple weeks in the end of your life, maybe when you're 99, and so you don't want to be frail when you're 80. When you're like almost 100 is fine if that's near the end. So you're really looking at increasing your mobility and ability to move and so on. And I'll talk about other biologic markers of aging in a moment. Next slide. So there's evidence of accelerated aging in persons living with HIV. Increased incidence of age-related illnesses at younger ages, which we just talked about. Accelerated aging has been repeated in numerous groups, and there's different biologic measures all support the fact that aging is accelerated. Again, you're seeing these features of aging, cardiovascular, diabetes, neurocognitive decline at a younger age. And we're also going to look at something new called epigenetic age. So now you have a chronologic age. Let's say I just turned 70. And so somebody says, Alan, you're so active. You're so, you look very youthful. Well, my wife says I really act like a teenager. I said, that's good. Maybe my biologic age is 20 or 30. So no, you probably couldn't go that. But I'll talk to you about the idea. We can now measure your biologic age, which would be a better indication of how well you'll do in terms of your health span. So now we have new opportunities in the lab to look at things and actually modify those. These are modifiable. And some of that data will actually be presented here at Freud this year. Next slide. So aging and HIV, how does this play into cure? Why is it important to understand? Well, are there unique features of older people that can be addressed with a cure itself? And we'll talk about that. What impact does age have on the reservoir? That comes up all the time. I'm sorry, yes.
Sorry, I didn't mean to interrupt your thought, but I wanted to ask a question about people born with HIV and what is the like.
You'll see, I've written that. Great question.
Okay.
So these are people now, and I'm glad you asked that. That is an absolutely brilliant question. So thank you for asking. And I'm going to talk about it with some data on a paper. So the question is, these are people now that are, in their 50s and 60s, and maybe, infected in their 30s or 20s. Okay, and those are what we study. But all as important are now people born, and this is, I know, folks that, we talked a lot with Dawn and others in some of her meetings, people who are born with HIV and, at birth, and now are in their 20s and 30s. And how do we deal with those people? And they aren't going to look the same. There are very similar features to those people who are now in their 30s and infected at birth. So, and I'll talk about that. And we're thinking about cure strategies there. We're going to deal with the same underlying issues. They do have increased cardiovascular risk and metabolic risk as well. So what impact does inflammation have on immune function? So as we know, and we heard from a lot of the speakers earlier, I wasn't here for all of them, the immune system is critical to a cure. And if your immune system isn't intact with applying whatever strategy, the strategy cannot be effective. So if you have a broken immune system or one that's impacted by inflammation, and then you take a cure strategy that's going to try to increase its activity and ability, but if inflammation there's this sort of, they're acting against each other. So you have the cure trying to increase immunity, and then you have the ongoing inflammation that's also going to decrease immunity. So who's going to win the battle? I think that's the idea. But we may have approaches that we can use to reduce that inflammation to then increase our ability to get a cure. And what role will studies of neuroscience and novel therapies have on future cure? Next. So here again, drivers and mechanisms of aging with HIV. All of these are important. Stress, trauma, depression, chronologic age, socioeconomic, lifestyle. What did we eat today? Did we eat a healthy meal or not? Well, you can decide what you ate and how many cookies you had. Exercise. Did you walk here today or take the bus or did you bicycle? When I got off on my trip to New Zealand recently, when I got off the airplane, my wife had arranged a bicycle trip up to the Inakwa volcano in Auckland. So, although true confessions, it was an e-bike. I have to admit that. Because these are really steep hills. Anyways, and we heard about ART and PrEP toxicity. How much of that's going to affect outcomes? And we have to be concerned, viral reservoirs and so on. Next slide. So we have to ask about the impact of hallmarks of biologic aging. And these are now what comes out of the whole field of aging, including things like epigenetics. People have heard of telomeres, the gut. What's the importance of the gut now? And microbiome is there. Inflammation, mitochondrial dysfunction is part of aging. And what could happen is, let's say you started drugs like AZT, the D drugs, in D4T, DDI, DDC, in your 20s and 30s. Now you're 60, okay? And now you're aging. There's effects of mitochondrial aging. How do those D drugs affect as well the mitochondrial outcomes? So there's a lot of things, and that experience of what you've gone through in your history of HIV infection could affect your ability of your immune system to respond as you age, and also then impact cure strategies. Next. So this is just going to show you that all of these can be impacted by HIV and ARTs. So a lot of impact So this wheel comes from the aging field, and then I've underlined that everything we're talking about in aging, HIV has impacted. So there's a complete intersection between what HIV does and aging does, and drives it more effectively as an acceleration. Next. So how do we measure age? I talked about chronologic age. Let's say you're 70, like me. And what's your biologic age? Which you want to be lower, not higher than your chronologic. And there's ways of doing it. So chronologic age is the amount of time passed since birth. Biologic age, measure of how old a person's body is. And that biologic age, your organs may not age at the same rate. So I might have a 50-year-old brain, but I may have an 80-year-old body. So that really isn't what you want either. Because then you're sitting there around because your body's too old to do, but your mind is still active and thinking. So we have to look at those careful aspects of the outcome. Biologic age is not perfectly matched. So they're not going to be in concordance with each other. They may be together, one higher, one lower. Again, what influences? Lifestyle. Again, what stress, socioeconomic. So it's not just the virus itself, it's also all the other factors that you live with every day that are going to affect your biologic age.
In socioeconomics, are you talking about family and hereditary and all that?
Exactly. Yeah, well,
some of the stuff is passed down.
Exactly. There's genetic factors.
Yeah.
So socioeconomic is what neighborhood do you live in? Do you live in a $1 million home, or do you live in a suburb or part of the city here in San Francisco that may be more of a low rent? And that's okay as well. Going to affect, are you subject to a lot of crime in the neighborhood? Is there what's going on in the neighborhood you live in? And so on. So there's lots of features here. And you can measure biologic age. So here we can measure biomarkers of aging. Digital, we can actually take and use measures from wearables. Now we're starting to employ those, like watches, Apple Watches, to look at that. And again, they can be, or non-wearable, like imaging. We can also do physiologic measures on functional performance. That may be things you do for frailty measures. But what we're now coming to are molecular. We're now using new science in the blood. And we're looking at things like epigenetics, transcriptomics, and metabolomics. And I'll talk more about this epigenetics because that's going to measure biologic clocks in the blood. So I take a blood sample from anybody, and I can now measure and determine I know your chronologic age because you tell me your birthday. I can now measure with this blood test your biologic age. And now can we modify that with certain drugs, and what happens in our HIV population? I'll show you next. So here's the first, evidence of accelerated aging at the epigenetics. So here's the idea of looking at the biologic aging, HIV and healthy. So HIV patients overall have a 5-year accelerated aging. So again, you're 5 years greater in this, and this was some original work done by Steve Horvath at the time at UCLA. So if you look here, this is blood, and then you can see it's 5 years older. So there's an age acceleration that he found in his early studies. The idea is that your biologic age is 5 years older than your chronologic age in an HIV versus a healthy donor in this study overall. So there's an effect that we can measure. Next. And epigenetic aging before and starting therapy. What happens? Does ARV affect it? This is a Lancet Healthy Longevity paper from the Swiss cohort some of you may be familiar with. So epigenetic age acceleration over time for this particular biologic clock. So the point is, you can see it does go down. So once, as you're looking here with your HIV not on therapy, you see an increase. So HIV itself seems to be driving this biologic clock to make you look older than you are based on your chronologic age. When you then go on therapy, it does come back and starts to normalize, but not completely. Next. And what this shows you is that it's highly variable. Some people, it continues to go up, some it goes down. So again, every individual in this room, you're going to be all very different. And a lot of other historical factors, lifestyle, we need to take a big history, which we're trying to do in populations now. Next.
Do you remember the Benjamin Button thing?
Yes.
No, long before all this medicine and all this, a whole lot of this research, people were finding out they were HIV positive. If they hadn't accelerated to AIDS, they were AIDS and they'll get the long fingernails and the baby hair and the skin and everything. So they were reverting back to babies.
Mhm.
You know, so yeah, that was long before all this stuff.
Yeah. I may be going on. What about my timing then? I can. Okay. So we're also doing this in accelerated aging, looking with the microbiome. This is a paper we just published. Next slide. And just keep clicking through. So we looked at individuals with the same chronologic age, HIV, with and without HIV. Oh, this is persons living without HIV and those on suppressed on heart. And we then looked at acceleration. In this case, we're just showing the fact that using these same clocks, you see an accelerated aging in the blood, but also in the gut. We actually took gut biopsies in these people. So we're able to see it in many different sites. So there's accelerated intestinal and biologic age. And even when we start looking across different parts of the gut, we see different aging in our HIV. So again, it's very fascinating why and how does that affect. So we're trying to understand that more. Next. So somebody was asking about the people born, this again, HIV reservoir and premature aging. This is for adolescents and young adults who have perinatal HIV. Go next slide. So this just says, again, premature aging occurs even in patients who acquire HIV perinatally. So this is making that point. Next. And this just shows you the pro-inflammatory cytokines are increased in young adults who acquire HIV perinatally. Next. And then markers of aging are increased, like telomere length and CD4 exhaustion. So again, if you get HIV perinatally, you also get this acceleration. Next. So what about targeting? Do we have therapies? Do we have ways of approaching this? Which is what everybody wants to know. So again, considerations and challenges, latently infected cells and cure, removing reservoirs, and then again, working with the patient, dealing with the whole patient, patient-centered care. Next. We have to consider geroscience now. Can we now look at biologic processes that cause aging? And can we slow this with geroscience approaches? So some examples that have already been used in geroscience are improved diet and caloric restriction. So just thinking about your diet and thinking about what you're taking, and we can try to look at that. That's been done in aging, and we could try to apply that to improve the person's health overall, to then think about that the impact of a cure strategy might be good. And then we have devices and repurposed meds. Next. So we're now looking at what we call cynotherapeutics, novel therapies for HIV and aging, those that kill senescent cells and those that suppress. Some of them are drugs you're familiar with, metformin used in our diabetes patients and rapamycin in transplants. Next. Cynotherapeutics themselves can impact the reservoir. So all of these drugs are being looked at as in aging studies, but they also have an impact on the HIV reservoir. So again, if you're going to study aging, you can get actually a double effect of taking and treating their aging impact and then also their underlying reservoir. Next. And dasatinib is the first study we're doing in the ACTG. Next. I've worked with Adam Spivak at Utah, so dasatinib for HIV-1 reservoir reduction. So this is now going to be starting within the next couple of months. Next. And again, initial studies suggest that dasatinib can reduce the reservoir. This is one of the main geroscience drugs, and they looked at HIV reservoirs and shows that it does decrease. Next. And was safe. We're also using a combination of dasatinib and quercetin on improving physical ability and cellular senescence. So this is an approach looking at aging in our HIV patients with the same drugs, and secondary endpoints will look at the reservoir. Next slide. And again, in this case, we're going to do impact on chair stands and walk. We're going to look at exercise capacity and then senescent cell abundance and many more studies. So again, we've got studies going to look at the impact of aging. Next. So aging and HIV cure summary, and then I'll give a little bit more of where we're going. Older adults have unique needs, need to be addressed with a cure, but are less likely to tolerate and respond to many therapies. Again, they're not going to respond. Again, I was telling you, the immune system is suffering from the aging effects and these accelerated aging effects and inflammation. So if those effects are still there, and you're then trying to cure somebody and then boost the immune system that can't be boosted, it's broken and it can't be fixed until you deal with that underlying cause with perhaps some of these geroscience approaches. Thinking about adding metformin, thinking about adding GLP-1 agonists, and we're going to be presenting the fact here that in one of our ACTG studies, we were able to show a slowing of the biologic clocks by giving GLP-1 in a study. So that's very exciting. We're also, I mean, everybody's taking, I don't know how many people here are taking GLP-1 in the room today. We're now starting a study in Galveston to look at this as an aging, effects on aging. No longer weight loss, but it's other important effects. Okay, impact of age on the reservoir, next, I'm sorry, go back.
Yep.
Is unknown but important. Again, chronic inflammation is a well-described feature, target of many therapies, including those developed in geroscience. So again, we have to deal with that as we're dealing with aging. Then my final slide. Please go back through the garden analogy. Again, HIV can accelerate aging like a super fertilizer can accelerate growth. Chronic inflammation from aging in HIV is like weeds, which disrupt the health of the garden. So we now have to use geroscience and new medicines to support healthy aging, and therefore then have an ability to take a good effect on cure strategies. And even some of those geroscience drugs, I pointed out, can have an effect on the reservoir. So it has a double benefit for everybody. Next. And this is just a picture of Old Red. This building survived. Have any of you heard of Isaac Storm? The hurricane that destroyed Galveston, where I lived in 1900. This building survived. And the dean of the medical school wrote the chancellor in Austin at the time and said to the chancellor, and it's actually in the chancellor's office, we closed for no storm. So the medical school did not close, and 2/3 of the island was gone, as well as the population at the time. But this building survived, and these are all my collaborators and funders that I've talked about. So thank you very much, and after the
What do you say now? Where does all that inflammation go in our body? Because all of us have been gathering inflammation for decades. So do we poop it out? Do we pee it out?
Absolutely.
Where does it go? Where does it go?
It does.
Because when they take blood, they don't take inflammation is in the blood too.
Oh yeah, it's there. You're
So,
not measuring it on a regular basis. So I mean, yeah, it goes and there's ebbs and flows, but it's still there at a low level. And if I looked in your blood, anytime you got blood taken, we could find that inflammation still there.
And when you said 1981, it wasn't HIV or AIDS in 1981. I'm just curious, what was it called way back then?
Grid.
It was GRID back then in 81?
Well, and
I knew it came around 80, 81, 82.
well, no, the virus wasn't discovered until 83.
Yeah, 83.
So,
The
but
French in 83.
huh?
The French in 83. It was 84 that we supposedly discovered.
They weren't taking out
Revisionist history. I know.
They weren't taking our blood in 82, 83, and 84 to see the antibodies in our blood.
No, but I did. I was looking for a agent. Our first study in hemophilia, we worked with Max Essex at Harvard. I have a science paper, and I did find a retrovirus, but it wasn't the right one. We found HTLV1 in our patients with hemophilia and this new immune deficiency. So yeah, I was taking blood, and I literally would come back to Birmingham, and there was no TSA. I would put tubes of their blood in my pocket, get on the airplane, or put it in a styrofoam container under my seat and come back and forth.
Lunchbox.
A lunchbox. Well, no, he's right. The person I worked with at Abbott, who actually developed, when we developed the first test in 1985 to screen the blood supply, he would come to my lab. I was growing the virus in cultures. He would take them, put them in his lunchbox, and take them home, put them in his fridge, and then take them from the city in Chicago up to Abbott. So that's true.
Thank you.